in just a second to Dr. Harris, who's the Acting Director of Pathology Queensland, to moderate this next part and to hopefully have a little bit of a discussion about what we have been moving forward. But if I could read that out. So the question was, can you offer advice for reporting, managing Pseudomonas infections with aminoglycosides, specifically with gentamicin? I'm inclined to report gentamicin should not be used as monotherapy. Combination therapy is required. Please discuss with Micro. Can you comment on the higher dose of amikacin recommended and any safety data from this? We currently use 15 milligrams per kilogram.
Yeah, looks like when I was going off to get a cup of coffee, so I'll start. My suggestion, that's one way of handling it, to put a note saying should not be used as monotherapy. We were unclear even after extensive analysis and discussion about whether it could be used in combination therapy for Pseudomonas. All the data favour tobramycin and adequately dosed amikacin, and I see that dosage question has come up with amikacin as well. So my instinct is, if you want to continue to report gentamicin, I would say the simplest thing is just to put a R, and you've got to have a tobramycin result to go with it. And I think that's critically important. So it has to be looked at in terms of, do you have a tobramycin result available? Can you report that? If you haven't, maybe that issue needs to be addressed first. You want me to talk about the amikacin dose?
That would be great, thank you.
Yeah, look, we had a long discussion about that because it's quite popular in the UK. They have the tradition of using 15 milligrams per kilogram. Pharmacodynamics is extremely clear. That dose is inadequate, and probably always has been inadequate. And we actually need 30 milligrams per kilogram. You need double the dose. That amikacin is fourfold less active than tobramycin, gentamicin against gram negatives, and everything needs to be fourfold higher. 4 times 7 milligrams for Tobra and Gen is 28 milligrams, because the kinetics is not that much different. So yeah, I know it's painful, and the drug's not cheap either. So all of those issues play in. That's why I think it's still a reserve drug, but if you're going to use it properly, I'll say.
And just before I hand over to Patrick, I might just ask one question myself. So, John, I think we were talking about this before, but in Australia we use amoxicillin and pagulonic acid twice a day rather than 3 times a day, which is recommended as a standard dose. And you sort of data there about hemophilus as well. Should we be encouraging a 3 times a day administration of amoxicillin pagulonic acid, or are we still sort of in our national guidelines able to support the twice a day dosing?
I can recall when the 875, 125 formulation was first developed. In fact, pharmacodynamics had bobbed up by that time, and it was clear that this is a time above MIC drug. And the company developing it were aware of it, and they actually looked at the time above MIC that you get with the twice daily dosing. And it was actually slightly less than what you see with traditional 3 times a day dosing 500. And they thought that was good enough to go, and so we've got used to that. It's certainly been my clinical practice if I've been treating anybody with a moderately serious infection. They've been getting 3 times a day, and I've been doing that for 20 years. So to me, the kinetics was, we can't afford to get that wrong if we're going to use it properly. It's really a 3 times a day drug.
I think what saves us is that, you know, most Haemophilus infections are not actually Haemophilus infections, and Haemophilus is normally not a very aggressive bug. So our failures will completely drown out among all those situations where we feel that we succeeded, but which was more a question of immunologic systems in the patients and and the fact that the Haemophilus we isolated from nasopharynx or whatever wasn't really very relevant. Can I just say about tobramycin and gentamicin? I think we've known from the 1970s, there is certainly literature all the way back to the mid-70s saying that tobramycin is more active than gentamicin on Pseudomonas, and that is probably the major difference when everything is said and done between gentamicin and tobramycin. And when John and I look at all the wild type distributions, it's pretty obvious that it's a twofold difference in MICs. And since the PK/PD, all the PK/PD speaks to a very narrow margin, that twofold difference, which wouldn't mean very much maybe with benzyl penicillin, but with an aminoglycoside, it means everything. So I think the only reason to ever use gentamicin for a Pseudomonas infection in my book would be that tobramycin wasn't available. And that is the case in some of the old East Bloc countries like Latvia. I don't think Croatia has tobramycin, and there are a few places around the world where tobramycin is not licensed. So that would make some sense not to use tobramycin because you can't get hold of it. But otherwise, I can see no reason except for tradition to want to continue to use gentamicin for tobramycin for Pseudomonas infections.
Hi, it's Patrick.
Hi, Patrick. Good to see you.
Hi, thanks so much for this stimulating discussion. As I'm sure you know, we've been wrestling with this problem quite a bit within PQ, and it's really helpful to sort of have your views sort of laid out so clearly. So look, I'll just keep going with, there's a few more questions here in the Q&A. I'll read this out for everybody. So from an anonymous attendee, I feel like I represent a middle ground in time between previous dichotomous cutoffs based on traditional antimicrobial dosing and a future where therapeutic drug monitoring is more widely available and dosing can be tailored to an MIC and serum tissue drug concentration. Do you think I will remain as is or will eventually come to mean therapy with this agent is recommended to be accompanied by TDM to ensure adequate drug exposure? Is this question written by Jason or?
Does look Jason,
Yeah,
right?
it sounds like it could be Jason or possibly Paul Ambrose. Can I go first, John? And
Sure.
You can fill in. Yeah, I think that's fantastic. You know, one day we will be there, and everyone will be performing MIC determination, or whatever we have reached methodologically by that time, and we will all have small pocket calculators in our mobile phones and what have you not. But I don't think we're quite there yet, and I think a lot of us need to shape up on our acuity when it comes to MIC testing before we're there. So there are a number of things that need to happen before we get there. So I think for the foreseeable future, we're going to need to use SIs and Rs. I don't see them branching into 4 or 5 or 6 categories, but I think we're going to need at least the 3 categories. What I think we might look at in the future is perhaps a double R. So when it's really resistant, maybe we need a double R, because there are an increasing number of situations where an R is actually not an R. If we're willing to go way beyond the accepted dosing, we could perhaps tackle some of those infections. But for some agents, that is not going to work, like I think trimethoprim sulfamethoxazole. It may work for meropenem, it may work for a few other beta-lactams, it may work for a few agents, but I don't think it will work for all agents. So maybe we will need R and double R in the future, but we're not quite ready to do that yet. So the short answer is no, I don't think we're going down that road very quickly, although we may get there in the end, but it will take some time.
I can just add to that. I mean, the bulk of testing that labs do is there for community practice when you look at it on a worldwide scale or even a national scale. And we're not going to be doing TDM in many of those. But I mean, I think TDM is grossly underutilised in hospital practice. And if Jason, you wrote that question, then you know my answer already. And you know, Jason's already shown the value of going down this path in the intensive care setting. And I think there are many other parts of the hospital, no doubt. Royal Brizzy, for instance, where that must be happening anyway. So I think that's a good idea. The big caveat that so few people are aware of is that a single MIC measurement is actually a hazard. And a single MIC, the assay variation on a single measurement is quite significant. Everybody thinks of it as being one plus or minus 1-2-fold dilution, but that can have a very profound impact on a pharmacodynamic index and therefore any dose adjustment. And I call an MIC measurement a sample from an MIC distribution population. And so you actually have to think about it as a statistical result and put it in a range and make sure you take the range into account. The pity is that we don't actually have that information except about what the range is except for quality control strains. And we don't know whether that's fair to extrapolate to every known isolate. So I think there's that side of the equation about using TDM and MICs to replace everything that also needs to be addressed. And it's probably harder to address than the therapeutic drug monitoring, I would say. I'll leave it at that.
Can I add to that, John, just to say that we're getting that data that you're now asking for in clinical strains, and the variation on repeat testing is roughly the same as when we use quality control strains. It increases when we get to the really resistant strains, the strains with enzymes and what have you not. It decreases when you look at strains that are uncomplicated from the point of view that they do not produce resistance mechanisms. So plus minus 1 dilution is sort of the best we will ever achieve, and we have to accept that for a number of resistance mechanisms, it's actually plus minus 2 dilutions and sometimes even worse.
So there's a question here from Narelle. So those of you who don't know Narelle, she's our sort of susceptibility testing guru, obviously Queensland, and has again been sort of wrestling up with Haemophilus for a long time. So she's asking, for Haemophilus, would you suggest that labs stop reporting susceptibility on isolates from non-invasive disease? And I guess I should predicate this on the fact that I have to admit we have temporarily stopped reporting from non-sterile sites. We can do it on request. Interestingly, we've had almost nobody request.
Yeah.
Apart from blood cultures or CSF or anything like that. As you say earlier, I've always been a bit suspicious that there's an awful lot of Haemophilus that we just pick up through, as a fellow passenger, not necessarily causing the disease. And it's interesting that we've had so little requests when we stop reporting. But I'm not sure what that says, whether our clinicians are just not reading the reports or what's going on. But we were finding that we were sort of pushing a lot of people to overuse things like ciprofloxacin or moxifloxacin. We thought was probably unnecessary, and spending a lot of time sort of agonising over this lift testing or doing lots of new tests that probably seemed to be unnecessary. So, interested in your thoughts on that.
If I can start, I think this can always be done in 2 steps. You can continue to test but stop reporting, and you can add a comment saying the result is available should it be needed or something like that. And as you say, for some bugs, we will then discover that the result is not needed once they get to think about it. So I think from a stewardship point, there's much more to be done by not reporting things than to discuss how we report things. So I would certainly advocate stop reporting Haemophilus influenza, and then following maybe a year or 2, I would then consider stop testing, because there is some money to be saved, I suppose, by stop testing. But there are other bugs in the system where we could have the same discussion, I'm sure. Pseudomonas being one of them. Yeah, I think we're actually doing an awful lot of. Sorry, John.
I've got to add to that. Yeah.
Sorry, John, were you going to say something?
No, I was going to say I had nothing to add. Gunner's covered it nicely. Thanks. Yeah.
Okay, so
we lost you, Patrick. I think you went to mute.
right.
Yeah.
So there's a question over here in the chat box from Andrea, I think, from MSD. How should pharmaceutical companies support appropriate dosing? Real-world evidence for a recently released antibiotic was high dose with high dose for pneumonia shows evidence of underdosing.
I think pharmaceutical companies are in a bit of a dilemma. They get a licensed dose and then they can't talk about anything else. So with the passage of time, we eventually get doses right, don't we, Patrick? But I would have thought that pharmaceutical companies themselves are in a bit of a bind, because if the licensed dose is less than what we now consider adequate, that's a challenge. If it so happens that they've licensed at a high dose for special situations, it's probably easier if we say, oh, well, that's the dose for everything now, to promote that. But we don't have a solution for them otherwise.
Can I add to that and just say there is another comment in the chat, in question and answers, about how the adequate dosing in the UCAS dosing table was determined, and I think that sort of ties on to this. And we don't have the PK/PD for everything, and of course PK/PD has been a very important tool for the discussions on review and revision of aminoglycoside breakpoints and dosing, quinolone breakpoints and dosing, temacillin breakpoints and dosing, phosphomycin, etc., etc. So it's not just new drugs that have been evaluated by, let's say, modern tools, to put it briefly, but also some older drugs. What we have also done to determine what should be in the dosing table is that we've gone out to all the member countries, if you like, all the UCAS user countries, with a dosing tab and said, look, guys, these are the doses that we have used when setting the breakpoints. These are the minimum doses that we think go together with S and I. And we now want you to check whether those minimum dosing actually tallies with your practice. And if it doesn't, you either have to come back and tell us, so we can adjust breakpoints in accordance with dosing practices, because a lot of people have a different opinion than UCAS about what dosing practices are, or you have to start a process whereby you convince your clinicians that they may have been dosing this agent in the wrong manner for many years, and that has happened. Both of those has happened. So, for example, in Croatia, a few dosing strategies have been changed, just to mention one place. And in the dosing tab, UCAS has heeded some of those comments that we've had. So I think the dosing tab is sort of a mixture of, or a synthesis of, PK/PD based dosing recommendations, or PK/PD dosing, and let's say the traditions of countries. We initially thought that countries would have very different traditions when it comes to dosing, but we were surprised to see that most countries actually have exactly the same dosing regimens, with a few exceptions.
Right, thank you. Yeah, I understand the analysis of wild-type Pseudomonas MIC demonstrates less susceptibility to gentamicin. Can you highlight any literature demonstrating clinical failure? Colleagues, quotes haven't seen it fail quotes or are reluctant to adopt these changes. And I guess this is actually a question that's certainly come up a lot with us. So when these changes were suggested, we put it out to sort of clinical consultation, and we certainly did have some feedback that, you know, I guess people are used to using gentamicin and believe it works and needed some convincing of its lack of efficacy. So I think you covered it a little bit before, but it'd be good to expand on that a bit more if you could.
Well, I might start on that one, Patrick. This takes me back to CLSI days when we started discussions about whether the breakpoints for third generation cephalosporins are appropriate or not. Remember when they were 8? And all the pharmacodynamic data said they should be much lower, you know, 2 or 1 or whatever, except maybe for ceftazidime. And I think for 4 or 5 years, the conversation rattled on at CLSI saying, show me the dead bodies. That people are failing when their MICs are above these new proposed breakpoints. The problem is that I tried to point out before, we don't actually have good monitoring systems. And to answer the specific question about gentamicin and can I demonstrate clinical failure, we did try extremely hard to find that literature. In fact, there's an extraordinarily good review done by Mikhail Paul's group in Israel looking at aminoglycoside monotherapy. It's not that old, so it covers all the historical literature that's available. And the number of monotherapy drugs studies where we could actually assess the efficacy of gentamicin are so low, and the numbers are so low, and the number of Pseudomonas must be a subset of that, wasn't even counted and reported in the publication. It's in Clinical Microbiology and Infection. We weren't able to answer the question. And of course, how often do we use these drugs alone? Hardly ever. Does gentamicin help a little bit when you add it to piperacillin and tazobactam, or you add it to ceftazidime against Pseudomonas? I don't know. The literature doesn't answer the question. Those studies haven't been done unless you go to the original mouse fly model in 1982, where Bill Craig actually started on pharmacodynamics before he even had the word, where he was dosing mice with ticarcillin and gentamicin and showing efficacy, but those were mouse doses. And they weren't originally designed to look at what the exposures would be like in humans. So unfortunately, I can't point to literature saying demonstrating clinical failure, and I can't point to literature demonstrating clinical success. So we're kind of left in that kind of clinical limbo, and with these old drugs we often are. And I would love to be able to help answer that question, but does anybody want to do the study, or you just want to use the better drug?
Yeah, and I think when you compare tobramycin and gentamicin, they are, as far as I can see, they are completely alike in all other aspects, basically, except that tobramycin gains you decidedly gains you 2 MIC steps in activity. I can see no reason. Sorry.
For Pseudomonas, yeah.
Yeah, for Pseudomonas, yeah. So I can see no reason not to use tobramycin for Pseudomonas, provided it's available.
So next one, will UCAS in the future have dosing required for different sites, i.e. bone, etc.?
So I'll start out on this one. I think the field to keep an eye out for is the comments field. I don't think we'll have columns for other infections than possibly UTI in the future, but we will possibly have comments in the comments field about you have to take care when treating this and that type of infection, blah, blah, blah. And I think you have to remember that the dosing tab in the UCAS table is not a dosing recommendation. It's a minimum dose to go with the S breakpoint and the I breakpoint. I've had Swedish colleagues say, we never give as little as that. So what sort of crap is this? And the answer is, of course, you can give more, we don't really care, but you have to make sure that if you give less than what is in that table, that you have some good background data to support your dosing, because as far as we can see, the dosing that is in that table is sort of the minimum level to make the breakpoints work. And then, of course, you know, treating meningitis on day 1 is different from treating it on day 3. And treating a knee infection in one patient is different from another patient, etc., etc. So I don't think the dosing tab or the UCAS guideline should be worked into a therapeutic guideline. We should stick to what we know best, and that is the pharmacokinetics, the pharmacodynamics, and the science behind the breakpoints.
So there's no more typed questions, but I might chuck in a couple of my own if you don't mind, but I won't keep everyone too much longer. I was interested about you. I saw in your slides that Japan had rejected UCAS and gone back to CLSIs. Did I read that correctly? What was the story behind that?
No, it's, you know, some colleagues are very irritated with UCAS because it sort of upsets their everyday work and they have to stop and think about things, and that's irritating. I know how irritating it is, so I sympathize with them. But of course, then sometimes people let slip things like, you know, if this is the way UCAS is going, we might as well abandon UCAS and go back to CLSI. And I just wanted to point out that as far as I can see, there are 2 choices. You can either start your own breakpoint committee. Actually, 3 choices. You can either start your own breakpoint committee. A lot of work, I can tell you. You can go with the Japanese, or you can go with CLSI. Those are the 3 options. If you go with the CLSI, you will be roughly 50% divergent from FDA, if you think that is any measuring tape.
And what have been the experiences when you mentioned places like Germany and Norway that have adopted this approach wholeheartedly? I get the impression that that ultimately has worked reasonably well. How would you sort of characterize that, like being too optimistic?
You start, John.
Yeah, I'd say that well, we have representatives on the steering committee from those 2, and they were responsible for organising the national education effort. You can imagine that in Germany it's 50 times bigger than Norway, population-wise. So they had Sarah and Gutterman on our committee spoke to that again last night, and they organised a large number of meetings, had a lot of discussions. There's always going to be a small number of disgruntled people. They communicate with UCAST anyway, and we deal with their issues one by one. I'd say, given that Germany's like Australia, all these labs are making their independent decisions, that's been a pretty significant move. Norway, smaller country, everybody knows everybody, rather easier to organise, and used to the Scandinavian approach of everybody sitting around the table and agreeing how to do something. Another country in that category is Slovenia. There's not a presentation from that. Slovenia is even smaller than Norway population-wise, but entirely cohesive in terms of they all sit around the table and decide whether something's good, bad, or indifferent, and all do the same thing. So I don't recall any negativity other than saying, oh, you know, Dr. X from Bonn is a bit irritating, but we deal with him. And in fact, Dr. X from Bonn emails us regularly anyway, so and we all deal with him.
It's actually Hamburg, isn't it?
No, it is Bonn, I think.
Is it? Okay.
Yeah.
Anyway, can I just add to that? Can I just add to that, John, to say that I think the GIST from all of them is that those that have now succeeded and are happy with the result all have to put in quite a bit of work to discuss this with their colleagues, to inform, to think about their LIS systems, to think about, you know, the way it operates in the lab, etc., etc. It's not something that comes automatically. You have to work at it and you have to put in an effort. And I think that was very evident from the Norwegian story, from the German story. The French haven't put that much into it, so they are a bit disgruntled still. The Brits haven't put all that much into it. They are totally swamped by COVID at this stage, and they still don't know exactly how to deal with it. But those that have dealt with it are now very comfortable with it, but they all testify to the fact that they needed to put some work into it and some thinking and some contact with their colleagues. And then at the end, they all say, and that was actually very good from a stewardship point of view, because we've sort of established communication lines that we didn't have before, and we've established the trust between us that we didn't have before.
That's right, and it's very relevant for us because obviously we're a statewide laboratory network.
Yeah.
If we make any changes, that applies to an awful lot of different labs, and that's an awful lot of clinicians to engage with, and they're not always easy to access. A lot of the small regional laboratories with people that are not necessarily infectious disease specialists or whatever, or have deep intimate knowledge of these. So that's been one of our anxieties, is about how do we re-educate the entire workforce. But as you say, it's probably a conversation that has to happen. And I guess just one last thing on a similar vein. Again, one of our anxieties has been, you know, if we make these changes, we then have to make changes across all our laboratories, which is quite a task just in terms of, you know, revising all the documents and getting everybody on board, retraining, etc., etc. There's always been this in the back of their minds. People have said to me, well, are UCAS going to change things again? I guarantee this is not going to be reversed and we can sort of press ahead.
No, this is not going to be reversed. I think the good news from that point of view is that, A, this is not going to be reversed. There is no tendency whatsoever in UCAS to reverse this decision. Everyone is actually very happy with the decision as such. Albeit, we all know what sort of work we are putting you to. The other piece of good news is that it will be a while before you have anything, any upheaval come to you via the UCAS breakpoint table. The changes that we're planning for 2021 and 2022 are all very positive changes. And they're really basically add-ons rather than changes. You will get new breakpoints for species that didn't have breakpoints, and you will get methods for species that didn't have methods. So it's more on the positive vein than, you know, the big psi type changes.
Well, that's great. Well, look, I don't think there's any more questions. We just got one last comment. Someone was asking about whether the session's been recorded, and I believe it has been recorded, limited as it is. So that sent out to everybody as a link afterwards. Yeah. So if you have been interrupted, or are we going to get to see the dogs? Maybe.
Yeah, actually, there was a comment. Someone wanted to see the puppy. It's not really a puppy anymore.
Puppy.
But this is one of them.
That's Joplin, right?
Yeah, no, that's Majo, actually, the brown one.
Oh, it's Majo. Oh, it's Majo.
Yeah, her aunt is over there somewhere in the sofa, sleeping, I think. Yeah. So there you go.
Well, look, I think if there's no more questions, I think, yeah, can't see any more coming through. And look, just really thank both of you for a great talk, and Professor Levine earlier. And I think we've got lots of food for thought. And, you know, we'll have to make a decision in the next few weeks about exactly how we handle this in Queensland. I mean, we will certainly move in that direction. It's just the details of exactly how we sort of handle some of the subtleties. We'll keep you posted on our experience, and hopefully it's not too painful.
Patrick, you'd be aware that UCAS, the UCAS workshop from ASA on the 12th of November. So we'll be going back over these. We will have presentations from Monash Health and from Royal Hobart have done it already. So we can get, you can quiz them as well if you might want to postpone your decision until you hear all that. It might be useful because clearly yours is a much bigger network problem, but I'm sure there might be a few clues in there somewhere.
Absolutely. All right, well look, I think on that note, we'll say thank you very much, and Gunnar for getting up so early in the morning and interrupting the breakfast, and John and Professor Levine for all your time. And we'll say, how do you say goodbye in Swedish?
Yeah, well, you can say it in French, adieu, or you can say hej då. Either will do.
Adieu to everybody, and yeah, so we'll keep the conversation going, I'm sure, elsewhere, and we'll meet again somewhere else in the Zoom world that we all live in. All right.
Yep, thanks everyone.
Okay. Thanks everyone. Bye now.